KRAS G12C is an uncommon KRAS mutation occurring in approximately 3 to 4% of patients with colorectal cancer. And targeting of KRAS G12C with a small molecule sotorasib had been previously shown to be quite effective in patients with lung cancer, as well as in a small cohort of patients with colorectal cancer who received monotherapy with sotorasib on a prior expansion cohort following the phase 1 first-in-human study. In the monotherapy arm, what we had noted is that the response rate was somewhat modest. Approximately 10% of patients at the recommended dose of 960 milligrams of sotorasib daily had an objective response, and approximately the median progression-free survival was approximately 4 months in that population. Those numbers, while still significant for a patient population that has progressed on systemic chemotherapy, appear to be less impressive than what had been seen in patients with non-small cell lung cancer with the KRAS G12C mutation. And it has been postulated that the reason for that difference in outcome and the more modest responses seen with sotorasib monotherapy in colorectal cancer is related to the feedback activation of EGFR, where inhibition with a KRAS inhibitor, sotorasib here, results in EGFR phosphorylation or feedback EGFR phosphorylation, which may represent an escape mechanism from sotorasib. In addition, preclinical modeling had shown that the combination of EGFR inhibitors plus KRAS G12C inhibitors are associated with synergistic activity in PDX models of KRAS G12C from colorectal cancer. And therefore, that's the rationale for looking at this combination. And what we have shown here at ESMO this year is that the combination of panitumumab, a monoclonal antibody targeting EGFR, plus sotorasib is clinically feasible with acceptable side effects. So the study that we reported on was a safety trial of the combination sotorasib plus panitumumab, followed by an expansion cohort at the recommended dose to look for signals of activity and to estimate response rates and progression-free survival in this patient population. The study design here is to start with the recommended dose level of sotorasib as monotherapy in combination with the recommended dose level of panitumumab as monotherapy. And the reason to start with these full doses is that we really did not expect to see any significant additive toxicities with this combination, especially that sotorasib is quite well tolerated. And indeed, in a cohort of 7 patients initially for a safety cohort, which is part 1, we did not really see any safety signals that suggest that the combination is not tolerable or that we needed to de-escalate either of those agents. So following the initial 7 patients, which is the safety cohort, we started the expansion cohort, which is ongoing, and what we reported on at this meeting is the outcome in 17 patients, the preliminary outcome in 17 patients who were enrolled on the expansion cohort. Now, to note here is that the safety cohort did allow prior KRAS G12C inhibitors prior to enrolling on the study. So in that particular cohort, we did enroll patients who had previously progressed following or on sotorasib monotherapy or in combination with other agents. And interestingly enough, in those 7 patients, we have seen some benefits, even in patients who have previously progressed on KRAS G12C inhibitors. So out of the 5 patients who had received prior KRAS G12C inhibitors, 4 patients showed some tumor shrinkage. And in the initial, in the safety cohort, we had 1 partial response, and that patient did not receive prior KRAS G12C inhibitor. So then we proceeded to the expansion cohort, and I have to say that the data is quite immature yet as far as the progression-free survival, because the majority of those patients are still receiving therapy on study. And what we have seen is that the majority of the 17 patients had tumor regression. Indeed, 15 out of the 17 patients had tumor regression in this cohort. And what we have seen in those 17 patients is that 6 out of the 17 18 patients had a response that is more than 30% by RECIST guidelines. But 3 of those patients, we have not confirmed the responses yet because it's too early in the study. But as far as responses, we have seen 6 out of 17 patients, which is approximately 33% of the population. The confirmed responses were lower because some of the responses have not been confirmed yet. Those patients are still too early in the study. And of course, the progression-free survival is too early to determine at this point. I think what is important to note is that, the toxicity is really consistent with what we expect with panitumumab here. It was mostly skin rash. We've seen electrolyte disturbances, hypokalemia, and hypomagnesemia. It is not clear that this is related to the combination or that there is an increase in the intensity of those toxicities related to the addition of sotorasib. The toxicities we have seen so far are very much compatible with panitumumab monotherapy toxicity. So very well tolerated combination, which is really a very good thing for our patients. We expect that such a combination for KRAS G12C patients hopefully will be shown to be not only quite effective in controlling the disease, shrinking the tumors, and prolonging the progression-free survival, but also be associated with a good quality of life in these patients. I think we really want to wait and see how our data matures. We would like to estimate the progression-free survival in this population. There is a follow-up phase 3 clinical trial that is going to be investigating the combination of panitumumab plus sotorasib in a third-line setting in patients with KRAS G12C mutations, and hopefully that would be a venue to show conclusively with level 1 evidence that this combination improves the overall survival and progression-free survival of patients with KRAS G12C mutation who had progressed on prior chemotherapy.